All right. Hi, everybody. I know there is still some of you in the back getting food, but I'm going to get it started. So my name is Jürgen Unitzer. I chair the Department of Psychiatry and Behavioral Sciences here. I'm really happy to welcome you to our grand rounds today. Today we have a very special treat. We have Theo Voss, who is a great colleague at the Institute for Health Metrics Sciences, introducing the session. And then we have a team from Australia here who are working with our Institute for Health Metrics Sciences to figure out what the burden is globally of mental health and substance use disorder. This is a team that has produced some numbers that have put mental health on the map in a way that none of us fully appreciate. Very, very important work and very exciting work. And I think we're very fortunate to have them here with us today. I think Alice Ferrari is going to present for the team, but you have a whole team here. So if you have tough questions for them, they can all take a stab at answering your questions. And with that, I will ask Theo to come up here and kick us off.
Yeah, thank you, Jürgen. Let me start with saying that I wasn't supposed to be standing here. We had hoped that Harvey Whiteford would have been here, also from the University of Queensland in Brisbane, but he didn't want to risk sitting in a plane for half a day with a slip disc. So he couldn't come, unfortunately. What I'll do is I'll just give you a little history of how this collaboration with the University of Queensland started in the more recent versions of the global burden of disease. So about 11 years ago, I was still at University of Queensland myself, and was partnering with this newly created Institute for Health Metrics and Evaluation that had just gotten a large grant from the Bill and Melinda Gates Foundation to revisit how we measure population health in the world and develop the methods to something a lot more sophisticated than the mostly spreadsheet-based models that we used before that. So by default, I was told you do mental disorders because by default earlier I was the only one who had really given much interest in looking at methods, looking at the data to quantify that. But it gave the opportunity with this rethink of how we do this to put a whole lot more science and content knowledge into it. And so an immediate choice for me was to contact Harvey Whiteford in the same university, and similarly to contact Louisa Degenhardt at the University of New South Wales? Yeah, and the National Drug and Alcohol Research Centre. To help guide the estimates. And then Harvey, being very inventive and very good at shaking money out of different government people, he then said, oh, well, I'll recruit all these young researchers. And of the original gang of 4, 3 are present here. One has moved on. All of them did their PhDs on how you measure mental disorders. All of them now are recipients of very prestigious fellowships in Australia. But there's a lot of continuity in the core people who've been working on this. And it's my great pleasure to introduce to you Alice Ferrari, who must be the only GBD researcher from the Seychelles Islands in the world.
I think so, because I'm pretty sure I know everyone.
Every one of this, what is it, 60,000 people?
80.
80, okay, population growth. I hadn't taken that into account. So she's going to give you an overview of what we've been doing so far on mental disorders, but particularly also saying, well,
Hello, everyone, and thank you.
Make sure that doesn't happen again.
All right. Thank you for attending today. So I just want to introduce the team that's here as well. So guys, do you want to just maybe stand up for a second? We've got Holly Erskine, who's our resident expert on child and adolescent and youth mental health. Damien Santamoro, who does a lot of the central severity work in GBD, but also is our resident statistician. Anna Mentia, who's very new to the team, she does the modeling of bipolar disorders and anxiety disorders. And Fiona Charlson, who's recently handed over a whole bunch of substance use disorders back to IHME Central that our team no longer models, but is also looks after schizophrenia in the GBD analysis. So these guys are here today to help answer questions as well. So feel free to ask questions as we go, if that's easier for you rather than waiting at the end. So there's a little window on the screen, which I'm scared to touch. So the next slide sort of introduced our team based at the University of Queensland in Australia. So we're, as far as I know, Theo, the only team who contributes to GBD kind of remotely in this way, right?
We have a smaller sized analogy with the air pollution people. They're relatively scattered outside of Seattle.
Okay, we're almost the only team. So yeah, we've got affiliations with IHME and University of Washington, and we link in remotely to all the training sessions for analysts at IHME on GBD, the meetings, the calls, the presentations that we're expected to give, and obviously all the analysis as well. And it's a system that's been working quite well for us for the last few years. So before I get into the nitty gritty, can I get a show of hands on who's heard of GBD? Okay, so almost half of the room. So there's a little bit of introduction on, the core GBD metrics, but most of the presentation is focused on how we estimate burden for mental disorders and substance use disorders. We'll go through sort of the high level findings for mental disorders, but then really drill down into the limitations that are specific to these disorders in GBD, and what we have planned to expand and improve on estimates in future iterations of GBD. So this you may have seen before. So in GBD, we measure burden using the disability adjusted life year, or the Daly, which in summary sums up the non-fatal and fatal component of burden associated with a particular disease or injury. So non-fatal burden is measured as years lived with disability, which to estimate, we multiply the prevalence of a disease in the population by its disability weight. Disability weight here being a weighting of level of severity associated with that disorder or cause. We measure fatal burden as years of life lost to premature mortality, or YLLs. And to do that, we take the deaths occurring as a result of that cause, and we multiply it by the life expectancy at the age death occurred. The majority of my presentation is really focused on the YLD part, because you'll see as I go through the results and also the limitations, that's where the bulk of the burden due to mental and substance use disorders coming from. We see very little, we are able to estimate very little burden coming from deaths and premature mortality out of GBD. And see some of you nodding, so you know this already. So let's see. So this table here summarizes the disorders for which we estimate burden for. You've got mental disorders in the first column, the substance use disorders in the second. All of these disorders are defined according to criteria proposed by either the DSM, so the Diagnostic and Statistical Manual of Mental Disorders, or the International Classification of Diseases. There are two causes that are not up here, and they're more what we like to term residual causes. So these are the disorders for which we have sufficient data to come up with robust estimates of burden. However, we know it doesn't capture all the mental disorders, say, in the DSM. So what we try to do is introduce a residual cause that, based on the data that we do have, we try to come up with an indication of burden. When we do that for other mental disorders as well as other drug use disorders. To estimate non-fatal burden, we use prevalence, as I said, but we don't only just focus our work on prevalence. We also need to understand or get an understanding of that disorder's entire epidemiology. So we're interested in incidence, remission, and excess mortality. And to get that data, we conduct systematic reviews of the existing literature to pick up on surveys that report on those parameters for mental and substance use disorders. So we don't obviously go out and conduct our own mental health surveys. We draw on data that already exists around the world. So we conduct really large systematic searches of online databases, looking at peer-reviewed literature, as well as gray literature sources, so things like government reports, sometimes conference proceedings, to try and find surveys that may not be in the peer-reviewed literature, but also contains data that we're after. We use rather strict inclusion criteria when reviewing epidemiological data for mental and substance use disorders. So we only include surveys that use samples that are representative of the general population. So clinical samples, for example, samples of inpatients or outpatients are typically not used because they're not representative of the distribution of mental disorders in the general broader population. That cuts down on the amount of data we have to work with quite a bit, and you'll see that in a minute. We also make sure that the case definition used in those surveys adhere as strictly as possible to the DSM and ICD criteria. We're very careful about not over-medicalizing just normal human distress. So it's important that our disorders meet DSM and ICD criteria. And you'll see the flip side of this and some negative impact this has on the estimates as well a bit later in the presentation. So this table here shows the data counts. So the number of studies we were able to include in our estimation of YLDs from GBD 2016. Those counts would have gone up for the most recent GBD 2017 that comes out in November. So with every iteration of GBD, we go back to the literature and see what else is new, whether there's any studies we may have missed, any new studies published. So with every iteration of the study where we build on our data sets and tend to be able to introduce more counts. But in 2016, you can see there's some disorders that we had more studies for, like major depressive disorders, some disorders very little, the eating disorders, the autistic spectrum disorders, for example. And something that's quite common across the mental health literature, there's a lot on prevalence because those types of surveys are less costly to administer, not so much on the other parameters. We're lucky in the sense that in GBD, we're most interested in prevalence, but the more we can find on the other parameters, the more robust an epidemiological model and estimates we can present. So all of our raw data from mental health surveys across the world that we've extracted, they get analyzed in a software package called DISMOD-MR, standing for Bayesian Disease Modeling Meta-Regression. Essentially what DISMOD-MR does is a meta-analysis and a regression. It's pooling all estimates, say prevalence estimates we have across different sources, and it's at the same time in a meta-analysis, and at the same time trying to adjust for known sources of measurement error in the data. And it does that through the regression bit. It is the approach in GBD is for parts of the world where we have no high quality data available, then we choose to estimate prevalence for those countries based on data that is available and also predictive covariates, if we have those to work with. The alternative would be to not estimate prevalence and therefore burden the countries where there's no high quality data available. And if there's no burden, often that gets equated to zero burden. And we don't find it defensible to say that in parts of the world, a lot low income countries where there's no data, that there is zero burden due to any condition in the GBD. So we predict data due to that. So DISMOD is the tool that allows us to do that. It also allows us to consider sources of uncertainty and carry that forward through to a final burden estimate. So it looks at the sampling strategy, the sample sizes used in our epidemiological data that we've extracted, epidemiological studies that we've extracted data for, and it carries that across all the way through to the final burden estimates. This here is just kind of to give you an idea of what we're doing in DISMOD and also the type of data we're working with. So in the first figure, what you see is a raw data set in DISMOD. I believe this one's anxiety disorders, and you have prevalence on the y-axis, age on the x-axis. Each cross represents a data point, so a prevalence data point that we've got to work with. The horizontal bar on the cross shows the age range that data point pertains to. The vertical bar shows the uncertainty around that data point. The intersection is the actual value, that prevalence value itself. And you can see there's a lot of heterogeneity. You know, we've got data points from ranging from 0, I'm pretty sure, all the way through to just under 40%. So there's a lot of noise in the prevalence data available for mental disorders. And what DISMOD or our analysis in GBD is trying to do is make sense of that, trying to remove the variability between studies that's due to measurement error as much as we can, but also at the same time trying to keep the variability that's true, that's real. And what we end up at the end is a pooled analysis where we've kind of taken the averaged, adjusted for certain covariates of all our data points, which is the second figure, and we end up with prevalence by age, by sex, for 195 countries and territories, and we do that for all the conditions in GBD. Those prevalence estimates form the basis for our YLD calculations. Next component of the YLD is the disability weight. And as I said before, that's a weighting that ranges from 0 to 1, 0 being equivalent to perfect health, 1 being equivalent to death. That gives us an indication of the disorder's severity. To estimate disability weights in GBD, for GBD 2010 and 2013, we conducted surveys, community surveys in a number of different countries, high, middle, and low income countries, as well as an online survey, which was available in a number of different languages, where we presented participants with different combinations of lay descriptions for all the different disease states we had in the study. So someone might have been presented with a simple description, very short, of severe depression, and the same for the conditions, all the conditions we've got. And they were asked, when presented with each pair, to make a judgment on which of the two descriptions they considered to be the healthiest. They were presented with multiple combinations of descriptions in that way. And in the end, all their responses were pooled on a scale of 0 to 1, like this, where 1 was equivalent to perfect health. 0 equivalent to perfect health, 1 equivalent to death. And that's how we, to summarize how we came up with disability weights. It's interesting that the description for acute psychosis was ranked at the most severe out of this entire exercise in GBD, out of anything else, any other diseases for which we had states for This is a difficult process because you're having to, there's a lot of debate around this part of the work, because you're having to condense in, is it 15 words or less?
I think with pilot testing, the struggle we found out, you can't ask more than, people to make a judgment on a description of more than 30 words, but that's less than 20 words, that was actually preferable.
Yeah, so you're having to condense this entire one disease into 20, 30 words or less. And, you know, there's different reactions you get from people, say, if you include a drug name in the drug use disorders description versus if you don't, you know, if they see the word violence or vomiting, or, you know, you tend to get different reactions from people, which then influence how they rate these states. Now to have a quick look at the results. This is a tree map, but you treat it as you would a pie chart. In its entirety, it's showing the total fatal burden estimated in 2016 across all the diseases and injuries in the study. And that little box I've highlighted here shows you the non-fatal burden that was due to the fatal burden that was due to mental and substance use disorders, which came to just under 1% of the total YLLs estimated for 2016. So not a very small amount, largely being driven by drugs and alcohol use disorders. Eating disorders were the only mental disorders for which YLLs were estimated for, and I'll get into this when we look at the limitations in a bit. But this also gives you, if you were to only focus on mortality, which before the GBD study is what people tend to do, this is the picture in terms of health loss you'd get. If you then start thinking of non-fatal burden and disability, you see a very different picture. So this tree map here shows the same thing, but this time looking at YLDs in 2016, and mental and substance use disorders explain just under 20% of the total global burden estimated for that year, which made them the leading cause group of disability in the world for 2016, if you considered them as a group, which paints a very different picture to what we see when we look at fatal burden in YLLs. The majority of the mental and substance use disorders burden is coming from major depressive disorders and anxiety, but you can actually see the breakdown of the other disorders contributions here. I should also say that all of the figures that I'm showing here are, they come from a visualization tool called GBD Compare. They're publicly available. You can access it through the IHME website, and the data is also downloadable into a CSV format if you want to work with it.
Warning, if you haven't done this before, you'll get hooked.
Yes, it's really fun to just look at this one more thing. There's different ways you can different figures you can use. You can look at things by age, by country, by rankings, by, yeah, it's addictive. Teo's right. This is the same thing again, but looking at Daly's this time. So combining our YLLs and YLDs, and we see that mental and substance use disorders explain just under 7% of the burden, making them the 6th leading cause of Daly's globally for 2016. I should have also, yep, sorry.
How do you decide how to group them? Because I'm a psychiatrist, I know how you came to the grouping of mental and substance use disorders, but if I look at the other things, how would you decide where to group and
Sure.
where to separate?
Yeah, so I should have said the colors, the diseases in blue are non-communicable diseases. The ones in red are communicable diseases, and the ones in green are injuries. Those are the 3 main cause groups we have in GBD, and then everything else is lumped in within those. Does that answer your question?
We actually have a very detailed hierarchy. So the 3 major categories is what we call our level 1 in the hierarchy. Then level 2 is conglomerates of diseases, like level 2, we have all the major childhood infections like pneumonia and diarrhea, vaccine-preventable diseases, etc. And then we break it down into greater detail at level 3, and we then have yet another level 4 where we have much more fine-grained details, like the distinction between major depressive disorder and dysthymia, or liver cancer due to hepatitis B, or liver cancer due to alcohol.
This is a stacked bar, and it's to give you an indication of the spread of Daly's by age. The different colors represent different disease groups in GBD, and it's for the year 2016. The mental and substance use disorders is the second lightest shade of purple. So, oops, let me do it. Just this group here. And it's really to illustrate the spread of the burden of mental and substance use disorders across the lifespan. We've got burden starting in babies, you know, with fetal alcohol syndrome and autistic spectrum disorders, and going all the way through to the elderly with, you know, chronic mental disorders, depression, anxiety, schizophrenia, bipolar. But remembering this is the Daly, so it takes into consideration both the fatal and the non-fatal contributions to burden. If we look at this for YLDs, the patterns across the lifespan change a bit. And what we always tend to highlight here for mental and substance use disorders is the bulk of the burden is occurring at the age at which you're expected to be at your most productive, so at working ages, and that you can really see in a graph like that. This one is showing rankings, so it's comparing the burden. It's ranking disease groups according to highest through to lowest burden imposed globally for between 1990 and 2016. And you can see that mental and substance use disorders here was ranked 7th and 6th, 7th in 1990, 6th in 2016. The burden due to mental and substance, to mental disorders, the prevalence rates don't change much of the time. We don't see a rate in the increase in burden. The increase that we see is due to population growth and aging. Substance use disorders is different. We do see an increasing in rates due to drugs and alcohol. However, the shifts in rankings here is not only due to mental and substance use disorders, but also how everything else is changing. If you've got burden for different conditions going up and down, then it affects where you are in the rank. And that's also what you see here. This is YLD rankings this time, so non-fatal burden only, and you can see mental and substance use disorders feature as the leading cause of disability in both 1990 and 2016. The second arrow is neurological disorders, just for interest, highlighting that as well. So you can see a lot of non-communicable diseases at the top of the YLD list, which I think is the big message here.
This, there are different ways in which you can do these hierarchies, and you know, we often print commentary. So we recently published, and we're actually currently publishing 11 papers on a different conglomeration of neurological disorders, where we take stroke away from the cardiovascular people and stick it with the neurological disorders. We take meningitis out of infectious disease and add it to technology. So there are these custom sort of aggregates that are possible, and particularly within interest groups, you know, they ask us a lot for these sort of things, because then, you know, a statement can be made that neurological disorders are the leading cause of disability and the second largest cause of deaths in the world.
This here, I hope it's not too small, but it's comparing Daly's across the GBD regions. So it's giving you an indication of how burden changes by region. Mental and substance use disorders is the row that's highlighted, and you can really see the variation in rankings. And I think this is for the top 25 leading causes of burden globally. And you can see, mental and substance use disorders rank as leading causes of disease burden in Australasia and North America high income, but then it can go down to, 10th or 14th? 10th leading cause of burden in sub-Saharan Africa. So there's a lot of and which is not surprising, because that's where we start seeing perhaps some of the more communicable diseases coming up to the fore. Yeah.
Just a general question. I'm confused about how you're dealing with overlapping conditions. So if you have schizophrenia and heart disease, how does you get marked as both, or how does that work?
Yeah, so in GBD, we remove the impact of comorbidity in order to be able to aggregate disorders in this way. So disorders, burden due to different diseases are first estimated in isolation. Then the impact of comorbidity is removed from that. And I'll talk a little bit more about work we're trying to do to improve this process a bit later, so that we're able to then add up, the burden due to depression to the burden due to anxiety and so forth.
Right, because especially with severe mental illness, we often talk about 2 decades of life lost, and it certainly seems that way from mortality in America. And yet, do you attribute that to cardiovascular disease, or you attribute that to having schizophrenia? And that's a big question about how to model that.
Yeah, you're absolutely right. And what we also do separately to sort of estimating the burden directly due to different causes is we look at risk factors and outcomes pairing. So we might look at child sexual abuse as a risk factor for major depressive disorder, and there's a whole series of risk factor outcomes that we can better tease out those attributions in that way.
As a corollary to that, how do you calculate the war and disaster statistics? To go through in 1990, it seems like there's been a lot of war and disaster. Maybe that's an artifact of reporting, but I noticed that didn't climb up much. It climbed up only one rung. But how do you separate that from the injuries and diseases?
Teo, do you want to answer that one?
So,
Yeah, we actually
I have a request. I got a text from the folks at UWMC. They can't hear when you guys are asking questions. So maybe
Just repeat.
you can ask short questions so that Alicia can repeat that.
So the first question asked just now was how we were able to aggregate burden due to different diseases and injuries. So how essentially we adjust for comorbidity in the study, which we do, and we remove the impact of comorbidity, which you've probably heard my response to that. The second question was how we estimate burden for war and disasters, which Teo will answer.
So we actually have a whole separate stream of work where we tap into international databases on casualties from natural disasters, from war and conflict, from large epidemics, because we treat them as what we call shocks. So we do most of our modeling based on run-of-the-mill regular sort of trends in disease, and then we separately estimate these large peaks that we know have happened. And for a lot of things, we rely on media reporting of numbers of death. And then there are actually international groups who consolidate that sort of information and make judgments on, if there's a range of estimates.
Okay. Some of the limitations to our method for mental and substance use disorders, well, as you've probably picked up from the table of data counts I showed earlier, there's a lot of missing data. There's lots of parts of the world where we just don't have that high quality data that we need to estimate prevalence for mental and substance use disorders. So we're having to predict data. So there's always, when we are writing our burden of disease papers, there's always, estimates of coverage or representativeness that we try to put in to give an indication of where we really need more mental health surveys conducted. And, it's unsurprising. It's in sub-Saharan Africa, it's in Southeast and East Asia, it's in those low and middle income countries that we really need more data. There's a lot of measurement error in our estimates. So it's really hard to tease out variation in our data, as I said before, that's real, that's due to ecological factors and variables that we want to preserve, but also variation that's due to differences in the method each survey will use to come up with estimates. We try and deal with that as much as we can in our inclusion criteria, which is quite strict, but there is still a lot of unexplained variability. And we don't always have a lot of predictive covariates to work with that helps deal with that as well. In our modeling of depression and anxiety disorders, for example, we include covariate on war and conflict to help guide our prevalence estimation, because there is a known association between war and conflict and the prevalence of depression and anxiety. But unfortunately, we don't have that for a lot of the other mental disorders to help guide the modeling. Zero YLLs is not the same as no increased risk of mortality. So that goes back to that first tree map I was showing this small sliver of fatal burden that's due to mental and substance use disorders. We know that there's a lot of excess mortality that's linked to mental and substance use disorders, but the YLL estimation process is not very good at picking that up. So what we do to estimate YLLs is we conduct reviews of databases like verbal autopsies, vital registries, and other mortality surveillance systems, all of which use the International Classification of Diseases Coding Index. And the ICD coding rules will assign a death to its direct cause, not its underlying cause. So if you have schizophrenia and you commit suicide, that suicide death, according to the ICD, and therefore in GBD, is allocated to suicide, the direct cause, not schizophrenia, the underlying cause. And suicide in GBD is in the injuries group, not in the mental and substance use disorders group. So in that way, we miss out on a lot of the, I've seen frowns in the crowd. We always see that when we say this. In that way, we are not able to capture on excess mortality and fatal burden where mental disorders is the underlying cause rather than the direct cause of death. The way we can do that is through our risk factor analysis, where if we use the example I used earlier, we would estimate the burden attributable to schizophrenia as a risk factor for suicide. And that's really the area we're trying to develop at the moment to try and better capture the excess deaths that's due to mental and substance use disorders. Question? Yeah.
Can I just ask, I was curious the thinking how it ended up in accidents and not in mental health to start. I'm sure there is a lot of.
So the question was how suicide ended up in the injuries grouping in GBD as opposed to the mental and substance use disorders grouping.
Yeah, well, to begin with, when we talk to our buddies, philosophers, and they're actually philosophers of causation, when we say, we cherish this tradition in ICD that there's a single underlying cause of death, and therefore we can do proper bookkeeping. You can only die from one cause, and everything adds up to 100% to avoid the often wild claims on numbers of deaths due to anyone's pet condition. But the philosophers say, well, it's actually nonsense, because there are lots of things that contribute, so they think, that this categorical attribution doesn't quite fit with philosophical traditions. We continue to do this because when we started working on burden of disease, And Alan Lopez went to all the program heads at WHO in the early 90s and said, how many people died from your disease, your injury? He stacked them up and he had 2.5 times more deaths than he knew occurred in the whole world. So there's not a small problem of advocacy-driven estimates that are wildly off and not constrained. So we continue to use that tradition of categorical attribution, and those 3 maps, they add up nicely to 100% across all these diseases. But it does mean you have to make some difficult decisions. Some of it is imposed with very strong preferences in the ICD. So anything that faintly smells of HIV gets to HIV, for instance. Similarly, the suicides, they are classified under injuries. Also in ICD, overdose deaths are classified under injuries. We've made a step and say, forget it. Those deaths need to be classified under drugs. But we have made a whole lot of these decisions. Some of them you can discuss. Luckily, we do have a way of alternate ways of presenting the data, and Alizé has been instrumental in attributing deaths from suicide to underlying mental and substance use disorders. But yeah, it is a little difficult to explain sometimes, and so you don't see in that mutually exclusive list all the things that you would expect to see.
I mean, ultimately, 90% of the causes of death is because you stop breathing, right?
Well, yeah, and so we deal a lot with that because there are vital registration systems where large numbers of deaths end up in cardiopulmonary arrest. Yeah, right. That's what happens to everyone who dies. So we call those garbage codes, and so we do extensive rehashing of those garbage codes and sticking them into more meaningful categories. Actually, people don't like the term garbage code. I think compost codes is much better. So,
could you give some examples? If you take out overdose and suicide, could you give examples of what you count as mental health deaths in like that little sliver?
Oh, so it's no, overdose is in there. So we, yeah. And the immediate alcohol deaths. So you drink yourself silly and you die from an intoxication. But for instance, traffic deaths, where we have a strong suspicion that alcohol played a role, they get classified under traffic deaths. And the sort of general rule there is, if in an individual you can say this was an alcoholic traffic death, then we would want to classify it there. But you can't say that. Lots of countries categorize like that. But your risk is higher when you're 0.05. It's higher again when it's 0.1. It's pretty damn high when it is 0.2. But you can't categorically say this person actually died because of the alcohol. The risk was much increased. And the same thing, you don't have anything like diabetic stroke, even though we know that when you have diabetes, you're at much increased risk of dying from stroke. So those are the sort of considerations we have.
That's really where the risk factor assessment comes to the fore, because that's really when you can start shifting and looking at attributable burden and seeing should you reassign that burden to different causes. In the example I used earlier, suicide back to mental and substance use disorders, the impact it would have. So it's really, yes, we do. Yeah, I mentioned it earlier. So eating disorder is the only mental disorders for which we estimate YLLs for. Yes.
Are the rankings, when you say something is 1, 2, or 3, are those statistically different, or are they just ordered? I noticed there's no tie.
We do have they're ordered, but we have uncertainty estimates around our estimates that allow us to tease out whether it is statistically different or not. Yeah, I just didn't show it. It was a very busy figure. Disability weights. As I said before, the whole world of coming up with these lay descriptions for disability weights is a difficult one and a challenging one, and there are biases, certain words, or even we've found the order at which certain words are presented in our lay descriptions that changes the disability weight. But the other thing to note is within GBD, in our disability weights, we only estimate what we think of as within the skin disability. We are not able to look outside of that. So we're not able to look at the impact of, the disorder on employment, on your work, on your productivity, on your functional impairment. The reason why we do that is we need to estimate disability for over 300 causes to be able to do that, and across settings, across countries. To be able to do that properly, we need to narrow our definition of disability. Otherwise, it's not something that's comparable.
Yeah, and I want to add to that, that was a deliberate choice, and we've gravitated over time in GBD more towards saying we explicitly want to measure health loss as opposed to general welfare loss. And the corollary of that is that in these international surveys, you see remarkable uniformity in how people reacted to the same questions. And by concentrating on health loss, you take out what people have postulated as large cultural differences in how people perceive the different types of disability.
And yep.
Question about that. So having folks that don't have a health condition estimate the disability associated with that, I was wondering if you think that overestimates or underestimates the actual disability, or if you have someone actually have that.
Theo has firsthand experience in answering this, so I'll let him.
I always ask audiences to guess between 4 respondents. Who do you think gives the worst and who gives the least severe severity? So the ones are general public, people in a condition, caregivers, and healthcare workers. So who generally gives the worst valuations? Who gives the lowest valuations? The worst first.
Worst meaning
The
highest level of disability. Caregivers, yes, followed by
workers.
why? Well, if they see it all the time, they would have a fantastic judgment on. Exactly, they tend to see the sickest people, and who give the lowest valuations? Yeah, you've heard this before. You've on the spot on, and part of that is questionable. Do you want to take that into account? So when a patient over time shifts how he or she values a health state, do we want to take that into account? So an example is a marathon runner loses a leg, world falls apart, but over time, 10, 20 years later, that person said, well, mobility is not so important to my health. It's cognition that I value most. And therefore, that person may actually rate health as quite good, despite having a serious impairment. And it's questionable whether you want to take those sort of coping mechanisms and adjustments into account. And hence, after having tried this in different ways, we settled on focusing on general population surveys.
And that was
reason to believe this is somewhat of an overestimate of the disability.
Why?
General population.
Why overestimation? I don't think you can use those words because it's a choice you make of what you want to pitch it at. Sure, but I just gave you an example where I think for policy making, the fact that that person says cognition is way more important and loss of mobility I don't care so much about anymore because I've moved on from that. That should not be driving your decision to stop investing in things that would lead to mobility loss.
in GBD 1990, published in 1996, which is the very first GBD study. It was actually clinicians, health professionals that who's responded to the disability weight survey and made this decision, and that was switched from GBD 2010 onwards for those arguments. Yeah.
I was part of a much maligned group of 15 or so international public health experts who for 4 days got all these grueling mind game questions thrown at themselves. And I had to it reminded me when Harvey had to pull out because of slip disc, because I had a slip disc at the time, and for 4 days all I could do was pace up and down and answer all these questions. So it was a pretty hard time.
So we know why the disability rate for low back pain was so high.
No, actually there was no valuation of slip disc.
Yes, okay. Let's skip to looking forward in GBD. There's a number of areas that we're working on improving in our estimates, which I'll try and hurry through. Increased granularity in our estimates. So like I said before, we're constantly looking for new data, ways of improving our modeling methodology, the predictive covariates we use in our modeling, and that gets better from iteration to iteration. We're really trying to focus on improving the severity data that goes into YLD estimation for GBD. At the moment, we have one set of severity splits that gets applied to the whole world. And we know that's not representative of the spread of the severity of mental and substance use disorders across the globe, which is more linked to access, to health access. So there is work in development to try and address that. And also our estimation of comorbidity. So in GBD at the moment, we estimate the independent probability of having two disorders, which is taken as the product of the prevalence estimate. In reality, really comorbidity is dependent. So your risk of one disorder might be different depending on what you're experiencing at that time and the added risk of experiencing something else. So it's a challenge computationally and with data to try and quantify that in GBD space, but we're working on that. We're constantly looking for new ways of adding new causes, new mental and substance use disorders into GBD, all ways to, which I don't have on the slide, to expand on what we've got. So personality and sleep disorders are often what we get, the ones we get asked why is not formally caused in GBD. And we are, for personality disorders at least, have literature reviews and efforts underway to look into formally getting that added. And also for disorders that are currently in, say, we had discussions this morning about perinatal depression, and we're keen to have that to understand the burden that's due, the burden from major depressive disorder that is due to perinatal depression. We're also keen to, at the moment, we estimate the burden due to any anxiety disorders, and it's also important to understand the burden due to PTSD separately, to GAD separately. So there are efforts underway to try and split that umbrella. This is my last slide. And it touches on things we've already talked about, but also expanding on the comparative risk assessment, the risk factor analysis component of GBD for mental disorders. In GBD's 2017, we managed to add in bullying, victimization as risk factors for depression and anxiety. That was a long process that Holly can speak to because she led the work, but we're also keen at looking at other risks, other forms of violence as well, added with where mental disorders is an outcome, and also the flip side of that, where mental and substance use disorders are risk factors for the health outcomes, which we've spoken about already. Thank you.
So big thanks to Alice and Theo for coming and sharing this work. This is work that's happening right in our backyard. We have a new department in the School of Medicine called the Department of Health Metric Sciences, and much of this work is in that department. And I think we are thinking about ways in which we can collaborate more. Because as you can see, these guys do some really, really amazing stuff, but it's fun to challenge them and to see if there's something we can do to help make that work better and contribute to it. I think Theo and I have an appetite for that, right?
Oh yeah, we love getting criticism.
And if you today's Friday, so my recommendation for you is if you have a little time over the weekend, log on to the IHME website and play with some of this data visualization tools. It's something you can get lost in for a good couple hours, and it's a lot of fun. And it gives you a different appreciation for what we do. The last thing I will say is, in many ways, these guys have been tremendously helpful to our field by telling everybody that we are, the #1 rank in terms of disability produced by any health condition. That's not something, though, that I'm terribly proud of. We are all the ones here who are clinicians who should do what we can to make sure we don't stay #1 rank forever, right? Because it's nice to be #1, but maybe it's not so nice to be #1, right?
Yeah, you'd like to get the position that in due time you're a neglected cause of disability.
So that's our task. How do we get down from #1?
Have a great weekend.